Good morning, everyone. I'm Justin Schreiber. I am a graduate of Archibald Board program and the associate program director for the program. And through that program, I did psychiatry. And so had a really amazing opportunity to be able to work for 6 months with Operation Safety Net. So it's an honor to be able to introduce our speakers to talk more about street medicine, especially as we approach the wintertime and think about the impact that the cold weather can have on those who are homeless. So, Dr. Anna Maria White is an assistant professor of medicine in the Department of Family and Community Medicine at the University of Pittsburgh School of Medicine. She provides primary care to adults and children in Squirrel Hill and is one of two doctors at the Adult Down Syndrome Center of Western Pennsylvania, where she offers specialized care for adults with Down syndrome. Dr. White has dedicated over 15 years to street medicine, beginning her journey as a medical student with Operation Safety Net, where she completed a rotation under the mentorship of Dr. Jim Withers, now her co-speaker, colleague, and friend. She serves as the medical director of street medicine at Pitt, an innovative student-led interdisciplinary team providing care to individuals experiencing homelessness, and the founding director of the Center for Street Medicine, which leads efforts to improve health outcomes and access to care for the population. Dr. White is an active researcher focusing on dementia and Down syndrome, mindfulness, and homelessness, addressing critical gaps in understanding and care for these populations. Dr. White is also the president-elect of the medical staff of UPMC Shadyside and leads the county's subcommittee on hospital discharges for people experiencing homelessness. A proud Pitt alumnus, Dr. White earned her undergraduate degree in English writing, completed her medical degree and training in internal medicine pediatrics residency at the University of Pittsburgh. Outside of her professional roles, she is a devoted mom to 2 boys. In her free time, she enjoys hiking, creating travel itineraries, attending her kids' sports events, and working on getting her dad's 1954 Chevy pickup truck running again. Dr. White is deeply committed to clinical excellence, innovative research, and community-centered care. For Dr. Withers, in 1992, Dr. Jim Withers, dressed as a homeless person, and joined a formerly homeless man to visit the street dwellers of Pittsburgh, making house calls at night. This initiative led to the program Operation Safety Net that brings medical care and social services directly to the undersheltered homeless. It also serves as a pioneering classroom for students of various disciplines to learn the principles of reality-based care. In 2005, Dr. Withers established the annual International Street Medicine Symposium with current partners in North America, South and Central America, Europe, Australia, Africa, and Asia to further collaborate in the care of those sleeping on the streets. In 2009, Dr. Withers created the new nonprofit Street Medicine Institute to promote global practice of street medicine. In 2019, Dr. Withers created the first Street Medicine Fellowship at the UPMC Mercy Hospital of Pittsburgh. Dr. Withers is in practice with the Pittsburgh Mercy Health System on the internal medicine teaching faculty of UPMC Mercy Hospital and an assistant clinical professor of medicine at the University of Pittsburgh. Thank you again, Dr. White and Dr. Withers, for coming to speak with us today.
Hi, everybody. Thank you so much for joining us. Go on. So I want to poll the crowd. Who has heard of street medicine before? Okay, everybody. All right. Who founded street medicine? Okay, good. Has anybody never heard of it? All right. Has anybody ever been out on street rounds before? Okay, awesome. Sounds good. Great. So these are our objectives. We're going to hear about the history, understand the need, and tie this into ACEs, because I think as pediatricians, there's a lot we can do to help prevent future homelessness, recognize learning opportunities, and find out how you can actively participate. So we will talk about what is street medicine. All of you have heard of it. So, but it's basically going to where people are and meeting them in their reality. Our system of making people come to us excludes those who need it the most. So if I ask somebody to come to my primary care office, clean enough to feel comfortable in the waiting room, be on time, have transportation there, get to the pharmacy afterwards, like that's excluding a ton of people. So we meet people where they are. We meet them where their needs are too. So if they are interested in housing, we try to provide that. If they are interested in just socks, that's fine. If they don't want to have anything to do with us, that's fine too. So we're going to watch a little video and then hear from Dr. Withers about the start of street medicine. So see if this will work.
So far.
Is there a way to get the volume up? I'm doing it over here. I'm pulling it up over here. Thank you.
I'm working on it.
I know. Sorry, thanks for your patience.
Excuse me.
Yep. Thank you.
It's my outfit I'm worried about. I could lose this eye. This probably is just gonna keep getting worse.
I don't know if I'm gonna make it through the winter. I just have too many things wrong with me.
Do you have a doctor?
I'm from the Hill District. Who in the hell up here got a doctor?
I'm Dr. Withers. We'd like to actually take you over to the emergency room and I'll walk you through there. 30-year-old female has recurrent cervical cancer.
Well, some of us don't like going to the hospital. Say, oh, they drug addicts, and why should we treat them? They're killing themselves.
Very quickly, I developed sort of a practice from one bridge to the next, one alley to the next, referral, so to speak.
That's the man right there. And God bless you, Dr. Will. God bless you.
We probably save this hospital around $300,000 a year. ER utilization, the length of stay in the hospital, decrease of readmission. And that's the tip of the iceberg. We will get you into housing if you want. This is a sense of place for him that's very important. And those bags, those garbage bags, are major things.
It's an agonizingly long process. These next 2 weeks are going to be the slowest 2 weeks of my entire life. I know that.
Get these opportunities, you take them.
Things have come to a sort of a crisis point, I guess.
Comes a time and you say you're gonna die on your terms, not nobody else.
People begin to understand maybe a little better the fact that there are living human beings out here that are dying.
If you want to watch more, there's a full 30-minute video about that. It's just the trailer. So. Okay.
So thank you for having me here. The connection with you wonderful people taking care of children and their needs and understanding where the adults that I generally treat come from and what they've been through, it is really hitting me hard this morning. And so I wanted to just, in a way of kind of sharing my story of my journey into this. I usually have a kind of a standard, I made house calls with my dad thing in rural Pennsylvania. But it's reminding me of some of the children that actually had an influence on really making me think deeply about healing, healthcare, and what we don't see. When I was a med student at Pitt, I don't think it was a third year, maybe fourth, but they had me on the pediatric oncology unit, and it was tough to be there. And there was a child named Akiba. She was an 8-year-old with leukemia who I didn't know, but people were talking about her, and they had a special speaker came in to talk about professional distance and boundaries, I should say. And it was about this girl because she was very engageable, and I guess there were boundary issues like how close do you get to your patients, to these kids. And I went into the noon lecture, and this woman that spoke was very convincing. I came out like, I'm gonna enforce my professional boundaries. That's what I'm gonna do. But I didn't know what Akiba looked like. And 10 feet from the door, as I was walking out, this little child, African-American girl came up to me and she said, I know where we can steal popsicles. And I said, yeah. So we stole some popsicles and we're licking away. And she said, what's your name? I said, it's Jim. And I said, what's yours? She said, Akiba. I'm like, no. And I had to make a choice at my young age there, whether I was going to like shields up or shields down. And I don't know. Maybe it was the house calls and the influence of my mom and dad, but I just couldn't turn off my curiosity about this brave little girl. And she was one of the two patients or professors, if that matter, that taught me the most in med school. We would go down for lunch or snacks, and her IV pole would go off, and I wouldn't know what to do, and she'd go and fix it. And she told me about her dad, who was in prison. She told me she wished I was her daddy, but she loved her daddy, and it was kind of heartbreaking. They let him come in once and in chains, literally in chains, to visit her. And then towards the end, when she was dying, I was one of only two people she would allow to hold her. And it was heartbreaking and it was carving into me. But I knew that carving was important. And it was opening a space, as Khalil Gibran would say, for more love, more compassion. And I'll dedicate this morning for me to Akiba. And she taught me so much. And the hidden curriculum, as you probably know, is kind of like what you're taught in terms of how we behave, who we are. And those things are oftentimes things to take pride in, usually, I guess. But oftentimes they're also things that have to do with power and control and racism and oppression and economic priorities and all kinds of other things that don't serve our patients very well, and they don't serve us because we become tools of our own making, our own industry, and the human element is lost. So it's very dehumanizing to our patients, but it ends up being dehumanizing to us as well. And so just to keep your humanity, you guys are already there because you're taking lower salaries and you're working with children and all those issues. But God bless you. You go where the pain is, towards where the need is, regardless. And I honor you for that. I think that's part of the nobility of our ancient tradition of being healers, and certainly as physicians. And so to capture that's a long intro, but I just definitely had to give Akiba her due. As a practicing physician at Mercy, as a teacher there, I felt that there's no classroom for recapturing your humanity and learning it. I did domestic violence work earlier in my career, and I realized that there's a reality every person, but particularly people who are excluded or oppressed or traumatized have. And to go there to kind of make the house call, even in the patient room, is not simple. It really requires deep, almost Mr. Miyagi kind of preparation, to be ready and have the right attitude to set the table, if you will, to make the deeper relationship that's going to take healing where it needs to go. It takes humility. It takes an openness. Osler saying, it's more important to know what person the disease has than to know what disease the person has. Those are things that are very hard to do in a busy hospital when your notes aren't filled in and your billing isn't submitted and everything else. And then you throw into that structural issues that intimidate and dominate people. And so the domestic violence victims that I worked with earlier in my career, I also owe them a huge debt of gratitude for allowing me into their lives and to try to learn how not to be an asshole, which is basically, I think this anus nisi or something. Don't primum non nocere, but there should be a second one, which is what Mike, a formerly homeless guy, that agreed to take me on the streets said. He said, "Don't dress like a doctor. Don't act like an asshole." Those were Mike's two rules. And at the time I thought, ugh, okay. I did dress down a lot. I tried to dress like a homeless person when I started going out, sneaking out at night. But over the years, Mike's second rule just has gotten deeper and deeper for me. And it's a good thing to do. But where's that classroom where you can learn that? It has to be out of your own power zone. It has to be out of your control. It has to be in someone else's reality. I love going overseas. That works for that. But I feel like we need to be looking in the mirror right here in Pittsburgh. We need to look at ourselves, look where we're a-holes, and how we can maybe work on that. You can't stop the liver transplants. You can't stop the important things that are happening. But we have to recapture our profession and our calling. And it's not easy. And I have huge respect for Dr. White's efforts and her whole career to do that and find others as well. And so that's how I got on the street, because I wanted to be in someone else's reality. And it was a hobby that really got out of control. And now there's a field called street medicine, and it's all over the world. And I love it. It has its own life. And a lot of that life can't be bought and paid for. Most of it has to do with the people wanting something that they're missing in their health lives. I remember one nurse who went through some medical problems out there in a wheelchair in Oakland making rounds. That's how much she wouldn't give up on this work. And I've seen it all over the world. So I think that much like Akiba, we can learn from those who are willing to let us into their lives, especially if we're not a-holes and we, are ready to learn. And then from that place of their reality, we can begin to, with them in solidarity, begin to kind of reconstruct this whole healthcare thing on principles of, does it really work for people? And do those people matter enough to make that the basis for what we're building? I'll finish my little section with the tagline for the Street Medicine Institute, which I saw in the Schweitzer Hospital in Haiti when I was down there. And these 4 words blew my mind. It said, "Go to the people." I thought, whoa, that's not just physical, that's in every sense. And it's attributed to Lao Tzu, and he is attributed saying, go to the people, live among them, love them, serve them. So you're starting at that place. Build on what they have, or start with what they have, build on what they know. And when the work is done, the people will say, we have done this ourselves. And so you can see the empowerment or the agency of our patients reclaiming their own lives is so central to everything that we're trying to do. And if we can't position ourselves in a way that little spark, can be nourished and built, then we're just we're losing out. And that's all I got to say about that.
Thank you, Jim. So when we were asked to give this talk, Dr. Spears asked about if we saw a lot of kids outside. We don't, thankfully, so there aren't many kids in the cases. But I want you to think about who these people were 20, 30, 40, 50 years ago, and if there was anything in their life that could have changed to kind of change that trajectory of their lives. Whenever we do see a child out there, we do get CYF involved. Even if we're not sure they're staying at the camp, just to make extra sure. We have found teenage runaways in camps before and gotten them safe and where they need to be. So thanks to the team for that. So. All right. So on to cases, and I want this to be interactive, so feel free to chime in. So this was whenever I was with Operation Safety Net as a med student. We were on street rounds in downtown Pittsburgh. There was a gentleman resting on a bench who reported a chest cold with non-productive cough and some increased shortness of breath. Found out he had COPD, hypertension, didn't have any of his meds because he was mugged. And he said he doesn't have a PCP because clinics aren't for folks like me. So we'll come back to that little point there. Second case, and we'll come back to these all later. Case number 2 at the winter shelter, which is opening this week, which is exciting because there's not many shelter beds available right now, which is terrifying because it's 22 degrees outside. So, but 50-year-old male with high blood pressure, depression, heroin use disorder, hasn't used drugs in 2 months, coming in with one of the worst headaches of his life. He says he has no chest pain, shortness of breath. Exam. Oh, he has a PCP, but hasn't seen this PCP because he said, I'm just too lazy. We'll come back to that too, highlight that. So his blood pressure is elevated, oxygen's fine, exam was otherwise normal. And the temperature outside was like last night, 26 degrees and dropping. The shelter locks at 9 p.m. What do you do? Any thoughts? Worst headache of his life. Yeah, right. So, so you worry about this worst headache of his life and you think he probably needs to be in the emergency room. So you recommend the emergency room and he's hesitant. Why do you think he's hesitant? Insurance, yep, definitely. So thankfully, a lot of our patients have insurance now. So like 80 to 90% or so have insurance, but definitely not everybody. So what else? Why else, Mike? What's that? Bad experience. Yeah, definitely. And I'll get to one of our research studies that's looking at that and trying to fix it. So. Yes, exactly. Yes. So the shelter's closing at 9. If he gets discharged from the ED, he might be out on the streets. Come back to that case. Case 3, 60-year-old guy. This was with street medicine at Pitt, living out on the streets of Oakland. He's out of his blood pressure medicine, and he's connected to a housing resource, and they're coming to see him that week because they said he's probably going to get a place. This was probably October-ish. So what do you do? He's out of his blood pressure meds. So when we're out on street rounds, we have a bag of like antibiotics, blood pressure medicines, Tylenol, ibuprofen, wound care, glucometer, blood pressure cuff. So any thoughts? Yeah, check his blood pressure. Good. So you check it and it's elevated. Yeah, great question. No, but we'll come back to that. Great question. So, all right. And then on to this one's sort of more peds than the other ones, but all of those people were peds at one time. So remember that. So this is a 20-year-old in downtown Pittsburgh on street rounds with Street Med at Pitt. She came over and she's like, hey, I have these staples in my head. Her hair was super matted. Can you take them out, please? They've been in for too long. And can you refill my Suboxone, please? Because I haven't been able to get to clinic because life is so hectic. So you can't submit Suboxone on your phone. So that night you're like in her chart and you're like, oh my gosh, like she saw like a pediatrician who's in Epic. So I was looking back and I was shocked, like 5 years old, abuse and substance abuse by her parents incarcerated, removed from her house to her grandparents, incarceration, abuse at grandparents, removed from their foster system, dropped out of school, substance use in the patient. Like I was almost in tears just reading this. And I'm like, oh my goodness. So what does this, well, I'll just give it away. How many of you have heard of ACEs? Yeah. So, all right. So ACEs are adverse childhood experiences in folks who are 18 or less than 18 years old. So these are the 10 original ACEs. So, I mean, if you look at these, I mean, she almost hit all of them, you know? So then I was like thinking, wait a minute, like, so how would this affect somebody becoming homeless or later in their life? So the theory with adverse childhood experiences is you have disrupted neurodevelopment, you have social, emotional, and cognitive impairment, impacts on life potential, which leads to disease, disability, and other social problems, and then early death. So I found this study in the Lancet Public Health. This looks at the lifetime prevalence estimates of one or more ACEs in the homeless population is 89.8%, which is here. And then in the global general population, it's here. So 38 to 39%. So yikes. And then they looked at 4 or more ACEs. So in the homeless population, it's here. In the global general population, it's only 3 to 5%. And we see kids with ACEs all the time, like every single day. So then what could we do to help maybe help some of this? So I thought this was nice. It was from the CDC website, and you can go read it all later. It's a lot of words, but some of the things that I really wanted to take away from this was strengthening household financial security and having family-friendly workplaces, high-quality childcare, safe dating and healthy relationship skill programs. So adolescent medicine is doing some of this for sure. Enhanced primary care. Like I think every pediatrician's office should have a social worker in it because I think there's ACEs all over the place. And family-centered treatment for substance use. And then how many of you have heard of Jeremiah's Place? This is near and dear to my heart. So Jeremiah's Place is a crisis nursery in Pittsburgh. And they're available for children 0 to 6 for up to 72 hours of care. So if somebody, like if a family member is going through a crisis, the children can go there and not witness trauma. And so they're wonderful. So another thing, okay, this is kind of outside the box, so bear with me. So Allegheny County is getting a huge opioid, or has been getting and will continue to get a huge opioid settlement funding. So in the tunes of like lots of millions of dollars. And so a lot of people are thinking about this, like for people who are currently substance users or currently using substances. But in my mind, like, why not direct some of this money to the kids, to the kids who are going through trauma, to Jeremiah's Place. I actually put in a request for money for Jeremiah's Place for this. But so think about like if there are needs that you think could prevent on down the road substance use disorder, like consider, you can go to this website, engage.alleghenycounty.us, and fill out this survey and put in there what you think is important. So think outside the box. And then there's a gentleman named Stuart Fisk from Allegheny County. So and he's in charge of this. So if you want to meet with him, let me know and I can connect you. Any questions or thoughts about that? Okay, great. So advocacy. All right. So I think that people on the streets are great educators, which is one of the reasons I was super excited that some students at Pitt asked me to be medical director of this student group. So there's a ton of continuity. So like last night whenever I was on street rounds, I saw people who I knew from, gosh, like for the past year or two, actually 3 years, one of them, and talking about Dr. Withers and boundaries, like the one gentleman saw me and he was like, "Hey friend," and like came up and gave me a big hug and I gave him a hug right back. So there's a lot of autonomy as a resident. I was often out on rounds myself and I had ability to call somebody if I needed help, but it's wonderful. Physical exam skills, you are important because you can't just order like a CT scan out on the streets. Got to be cost conscious. You often see emerging diseases out on the streets. And Dr. Withers always says that the relationship is your lifeline. And so I take this from the streets to my family, to my friends, so it's a great teacher. Triaging, this is me back as a med student. So triaging is super important on the streets and kind of reminds me of the emergency room a little bit. So you can have somebody coming up to you asking for chapstick and then somebody overdosing in the corner. So you've got to kind of keep your eyes open. Mobile resources have come a long way. Body language is important on the streets too. So this isn't as much a problem at Children's as it is in some of the double rooms at Shady Side or other hospitals. But, if you think there's somebody sitting on the street, like picture somebody sitting here with their back against the wall. If we have a team of like 8 people and we surround them, Like, how do you think that person would feel? And so thinking about that with a patient in a bed in the hospital too. Problem solving, there's a ton of problem solving out there. So homelessness exacerbates existing health problems. Colds become pneumonia, cuts become infected, depression becomes psychosis, and you'll often see advanced stages of everything. Drains left in, hypertensive emergencies. And so then it led me to think, like, why is the pathology so advanced? And I think it's barriers to care. And I think this is something that we can take from the streets back into clinics and hospitals and life. So do you remember case 2, the guy who said I was just too lazy? So imagine the most challenging time of your life. Like, let's say, like, maybe for me, it was like, super busy, like on Q4 call or something. And it was like, I hadn't done laundry, I hadn't grocery shopped, anything like that. Is that going to be the time that I'm going to go to my PCP and be like, hey, I'm here for my annual exam? Like, no, not at all. So multiply that by 1,000,000. These, they're trying to find food, they're trying to find housing, they're just trying to survive. So health kind of falls down to the bottom of the priority. And I was excited. This was an article in Pediatrics back in 2005. So go Peds. All right. So the average life expectancy in the US is 78 years old. What do you think it is for folks experiencing homelessness? And shout it out. Not 53 to 62. Good guess, though. 42 to 52. Yeah, sadly. The things that kill the older folks in that group are heart disease and cancer. So I was super excited to be able to work at the Second Avenue Commons Health Center and check lipids and prescribe statins because that was wonderful. But yeah, sadly, it's 42 to 52. Many of the people I met with Operation Safety Net have died, and that was only 15 years ago. So. All right, so this is from Dr. Withers. While initiatives such as patient-centered care, the medical home, medical and motivational interviewing strive to build healthcare around the individual, street medicine is a more radical attempt to create a care relationship on the terms of those who have been largely excluded from our system. So I love it. It's radical. It's out there. It's meeting people where they are. So some practical things, whenever you're seeing a patient, rather than asking them like, where's your home or what's your address? Like maybe say like, where are you staying? So that it doesn't feel like they have to have like an address for you. If you're not sure they have a fridge, maybe make sure that, make sure they have one if you need to prescribe prescriptions needing a fridge. Make sure they have a safe place for their meds. One of my patients was on gabapentin and I prescribed gabapentin several times, and every time he picked it up, he would get beaten up as he was leaving the pharmacy and his gabapentin would be stolen. And the third time that happened, he ended up in the ICU with a skull fracture. And so I was like, oh, I need to do something differently here. So I talked to the pharmacist and we did blister packs that he could just like put in his pocket and walk out of the pharmacy, and he was fine after that. Knowing resources, so I'll give you some of those. Writing down information because there's so much going on, it's sometimes hard to remember. And then eventually trying to get them a medical home if they're ready. So this is a lot of words, but this is on the Allegheny County website. And if you're like, I met somebody who's homeless, what do I do? This is really nice because it goes through the Allegheny Link phone number. If there's a family with children, they can get housing that night. So they just call this number, they'll get emergency housing. And then otherwise they can get on a list to get housing. Second Avenue Commons is a great touch point too. So like if you direct people to Second Avenue Commons as a shelter, they'll get them where they need to be. The winter shelter is opening up this week. And then if you're doing a history on somebody who is experiencing homelessness, this is out of USC, the Feldmans. So it's the mnemonic is housed bed. So asking about like their homelessness history, how long, where, who they're engaging with from an outreach standpoint, because then you know who to connect with, what kind of services they're utilizing, income, how do they get food, what do they drink, where do they use the bathroom, which is so important because that can lead to arrests if they don't have anywhere to use the bathroom, and then they're in the legal system, and then that impacts everything, where their camp is, what their daily routine is, and any substance use. And then, gosh, I could talk for a whole hour about this, but so there's a woman named Julia Lamb who came out with us once on street rounds a couple years ago, and she'd never been on street rounds, never done street medicine before. She was an occupational therapy doctoral student. And she said, I'll be back next week. And that wasn't how our schedule works. Like you have to like schedule in advance and usually go out once a month. But I was like, okay. So she came back and she kept coming back. Within a few months, she was president of the Street Med at Pitt student group. And then after graduation, within a few months, got a 2-year fully funded grant from the Hillman Foundation to start outreach therapy. And now she is, she actually was trained at Western Psych, helping people who were in the psych hospital reacclimate to life, like outside the hospital in their homes. And she's doing the same thing for people who were experiencing homelessness, who are now housed. And she is a rock star. So if you have anybody who needs some OT support, she's wonderful. All right, back to the cases. All right, do you remember the guy in Oakland who didn't have his blood pressure meds? So we asked him, like, what are your priorities right now? Is blood pressure your priority? You know, like what is important to you? And he said food and housing. And he said that for him to get his meds, he'd have to go all the way up to the VA, wait in the emergency room, get them filled, and it would be like an 8 or 9 hour day in his mind. And he would miss possibly his housing worker. He would miss his food for the day. And then so the resident actually who was out with us knew his PCP, contacted the PCP. PCP's like, oh, no, they're at his pharmacy. He can just pick them up. We got him a bridge supply, thanks to Birmingham Free Clinic, who supplies us our medicines. So thank you to them. He was able to get his meds and he ultimately got housed, and I haven't seen him back out. So. All right, case number 2, the guy with the super high blood pressure, the worst headache of his life at the shelter. So we talked to the shelter supervisor about his situation, and she said, you know, he can come back if he's not admitted, gave him bus passes to get back. And we told him, like, you're not lazy, you're surviving. And he was like, you could see visible relief that like we understood, and then had him follow up for Operation Safety Net. And then the guy that had COPD and the cough, who got his meds stolen, I met him back in 2009, and intermittently saw him during my time with Operation Safety Net. He ended up housed. And then a few years later, I think I was in residency, I saw him coming out of the winter shelter. And I was like, oh, like he's back out of housing, and like, what's going on? But he felt so strongly about the kindness that the folks at the winter shelter had shown him that he wanted to give back. So he organized his house, like his 3/4 way house, to collect blankets and make sandwiches to bring back to the shelter. So it was great. It was like a scene out of a movie, like us running towards each other on Smithfield and hugging each other. All right. So do you have anything you want to add about? Then I'll go on to street med.
Yeah. So I got another guy that was a teacher. His name was George. I met him early on. And so I remember there was a guy named Grandpa. I thought of him because I was driving over here, and the last place I saw him was actually, it used to be a rehab, the 80-year-old gentleman. And he was a professor of, can you adapt to my reality? But George was a professor of, do you frickin' respect me? And so we used to use George as a stress test for new volunteers. I don't know if you ever met George. Okay. So she's been through the stress test. He was an imposing African-American man that lived by the river, along the Allegheny River. He was a Vietnam vet. He drank a fair bit. And he had, I think, bipolar disorder as well. And slowly, George allowed me into his trust zone. And he went from, scaring the hell out of me to declaring me as his brother, which to me was a huge emotional accomplishment, to just be in that space with him. And I thought I'd figured George out because I had checked all the little boxes. African Americans are always way overrepresented in the homeless population. So he'd had that sort of background. He was a Vietnam vet. He drank. He had bipolar disorder. Check. I understand George. And one night, I don't know if he was sensing that I thought I knew him, but we were sitting around the campfire, and he said, "Doc, I got to talk to you. Come over to this log." So we went up the river a little bit, sat on the log, and he said, "When I was a kid, our mom brought us into to the living room, and she gathered us around, and then she put a gun in her mouth and she blew her head off. And we didn't know what to do. So we tried to make her look okay until a grown-up would come. And I was just, whoa. And then he said, you know, do you have any more of those McDonald's gift certificates? You know, whatever. It just boom. But he just kind of did one of these. And I never really talked to him much about that afterwards, but I think he just wanted to show me where it hurt. And I'm always amazed at the effect that childhood has on the people that we serve. LGBTQ identity is something I also had to really become aware of. I couldn't figure out why so many people on the street were gay. And then I slowly dawned on me because they had to run away from home. They were rejected. And this is the only people, if you do see that film, One Bridge to the Next, Bill speaks about that eloquently. But, you know, my final thought on this was that for a while, I was involved in doing home visits to people who had achieved apartments. And it was great because these are people I knew on the riverbank or under the bridge. And now here they were in their apartments. And I think that's in the film too. But it was a chance to celebrate their accomplishments. But one of the things that happened was is integrated into the behavioral health team. And so I'd come to the meetings, and I looked up on the board one day and I saw a blackboard where they had drawn a timeline of one of the people I thought I knew really well. And they'd mapped it out. Maybe you guys do this. We'd never thought of doing this. And every adverse or major event in their life was marked. And it just completely changed my thinking about that person. So the story is important. Sometimes we only get snapshots, and structure forces us to just see someone in a little tiny window. But the more the narrative arc of someone's life is taken into account, the more chance there is, not just for their blood pressure to get controlled, but for you to be part of that narrative that they can then begin rewriting for themselves.
Thank you. Yeah, there's a great book called What Happened to You? So reframing instead of what's wrong with you, like what happened to you. So I'll tell you a little bit about something near and dear to my heart, Street Med at Pitt. So it's a student-led interdisciplinary group that was started 3 years ago. We have grown ginormously since then. And we have didactic events research. You can follow us on social media or go to our website to find out about those. We volunteer in the community, and then we do street rounds every single Wednesday night. So I want to give a shout out to Dr. Bob Hickey, who is back there in the back row, for every single Wednesday night he comes out, wind, rain, snow, everything. He's out on street rounds, leading a team downtown and being amazing. So thank you, Bob. So we go out downtown. I lead a team in East Liberty, Shadyside, Oakland, Squirrel Hill, or some combination of those. We have packs, we have supplies, thanks to the Cooper Fund. We have amazing food, drinks. We also get leftover food from Pitt. We're super interdisciplinary, so I think it's up to 28 plus areas of practice because we added engineering too. So yeah, so a lot of folks just want someone to listen. So even if folks aren't medical, we welcome them out. Requires a greater degree of flexibility, problem solving, and empathy. And then I'll just go through some pictures from street rounds. Becky is one of the founders of Street Med at Pitt. She was formerly homeless and trafficked in Buffalo, and just finished her PhD here in Pittsburgh and is amazing, and helped found this group. And more street rounds. We, at the end of the night, well, I'll get to that, but we do a one-word check-in. And I just talked to the Peds ER folks about that. This is my car at the beginning of the night and at the end of the night. So we go through a lot. There's, gosh, in this picture, there's dental, public health, occupational therapy, social work, undergrad, PM&R, med peds, medicine, nutrition, nursing, maybe missing someone, but, and see if you can spot a Peds ER doctor in this picture. Do you see Dr. Hickey back there in the back right? All right. So how can you get involved? So the Street Medicine Institute that Dr. Withers founded is amazing. They have an annual symposium this coming year's in Hawaii. So super excited about that. Do you want to talk more about the fellowship?
Oh, yeah.
Yeah.
So we were able to launch the fellowship at UPMC Mercy in 2019. It's available to those who've graduated from internal medicine, emergency medicine, psychiatry, and peds. Yes, sorry, med peds. And it's a one-year fellowship. It's not accredited at this point. We were the first, but then Fort Worth followed shortly thereafter, and they have a great fellowship as well. Their current, most recent graduate is now in Dallas, and she's spearheading the first street medicine program in Dallas. So it's really good. It's focused on developing the skill set that one would need to do care on the streets. It's also, though, has a component of understanding the structure of healthcare and how it affects the experiences of people who have been excluded in a more general way. There's some teaching of students, an expectation of a publication, and a national speaking experience. But my favorite part, actually, I think, is we travel to other cities, mostly in the U.S., but always somewhere overseas. And for some reason, India seems to be where we end up going to look at what it looks like. It's almost like comparative anatomy when you say, oh, yeah, there's the skeleton. But if you look at a turtle, it's got a skeleton too. And it's, you get the point. And so the application of the underlying principles to different settings and stakeholders and such, because it's a grassroots movement at this point, will help the fellow to be part of the leadership of developing this as a field of medicine. It's a lot of fun. And so, yeah, if anybody's interested, let me know.
Yeah, thanks. Yeah, and y'all are all welcome to join us on rounds. I do consults at Shadyside. I'll show you more about that. Dr. Max Hurwitz, who's the assistant medical director and is a wonderful advocate and doctor, is also doing rounds. He does disability street medicine, so he goes out on Wednesday mornings. You can advocate. There's a lot of stuff, Supreme Court and otherwise, even local. You can follow us on social media as Start a Drive for one of our street outreach groups. And then I'm just going to fly through some research because that's really taken off. I just went to the engineering students who built this sound barrier for, the camp along the jail trail where there's the parkway and then there's a camp right there. So they built a sound barrier because the decibels there were ridiculous, and trying to have somebody sleep there is terrible, or even trying to have a conversation. High sound is bad for mental health. So that was great to see them. Couple med students, first years, approached us about doing a telederm research project. So Taylor and Simone are working on that. So we'll do e-consults on the streets or empower patients on the streets to do e-visits themselves. We just got a Beckwith grant to start to get a social worker for the street medicine consult service at Shadyside, which before that it was just me. So super excited to have a social worker. And Max, Dr. Hurwitz is leading a study that I was talking about earlier about looking at people's experience in the emergency department who are experiencing homelessness, and then taking that qualitative research and then making a curriculum for all the local emergency departments. So excited about that. Antonio made this project, which is so cool. We did CPR, Narcan, and Stop the Bleed training under a bridge in the South Side with people experiencing homelessness, and then some focus groups about that. And it was super interesting. And then I started something at the end of street rounds, doing a one-word check-in. So at the end of the nights, everybody says a one word. And I presented this to the Peds ER group too, that this might work for like debriefing from a tough rounds day or a tough night call. So strength, circumstances, concern, team spirit, privilege. Somehow zombie apocalypse was a word last night, and otherwise grateful was a word. So, and then this is, do you want to talk about the wall?
Yeah, real quick, I'm glad she talked about reflective component, because it's not always practiced in programs, but it's super important to do so. And so the digesting of the experience is really important. Not just because sometimes it's shattering what you saw that night, or troublesome. I know I depend on the month that fourth year students are with me. I depend on someone in the healthcare system to be an asshole, because that is a lesson that then has its own discussion. And I'm never disappointed. Someone always doesn't treat someone very well. And not to look at them as the enemy, but a chance to think about how is the structure making us all not the humans that we are, the people that we want to be. But so here, this memorial wall, back in '96, I finally, the media had been chasing me to do stuff, and I held them off and held them off. But I also had tried to publish, and it got rejected. Maybe it was my writing skills. But People Magazine came and said, we'd like to do a 6-page spread. And back in those days, I looked pretty good. And so I said, sure. And so when that happened, boom, I got communications, kind of before email, I think, but I got communications from everywhere. And one of those was Sidney Sheldon, the author, and he sent me a check and he said, you should be cloned. Here's $1,000. And I thought, this is in my name. This is pretty cool. I'm going to use this for something that's been bugging me, because it was accumulating. The grief was accumulating of the people that I feel I had lost, or that had been lost to this world, that were courageous. And, you're so deep in the narratives that it's hard enough, especially if it's kids, I can't imagine, but you have to process it in a deeper way than most internal medicine practices, at least. And so it felt like people were being tossed aside. I worked with the medical examiner from the beginning to keep records of all the deaths that I could. And a few of them were just unclaimed bodies that nobody knew. And so that grief, but that anger was building. And I said, I know what we're going to do with these, Mike. We're going to buy plaques, and they're going to say, we remember. And so we go back to everyone we could remember that died from '96 before. And we're going to stick them wherever the person had died, like they do with bicycles now. So that we remember their name and the year that they died. And the police pointed out, you can't do that. So one of my adages is, do the right thing until you get caught, and then try a different way. Thoughtfully, hopefully. So I went to the Mayor Murphy at the time, and I explained what I wanted, and I was like going to demand. He said, why don't you put them on a wall? We'll give you a wall. I said, that's actually a really good idea. So since then, every December 21st, coming up, we have our annual homeless memorial service. It's a national event, but we have a wall where we put the plaques up on the wall, and it's been copied in a few other cities. But this thing on top there, I co-wrote with one of our nurses who unfortunately passed away. In memory of those who lived and died on our streets, we believe you're no longer cold, hungry, lonely, or frightened. May you watch over us from a warm, caring home above. Yeah, so you're all welcome to come if you're free. It's usually a cold night. I think it's a Saturday this year, December 21st at 7.
All right, so take home points. We have 2 minutes left. Meet people where they are in all of life. Go to them, listen and learn. And I think folks experiencing homelessness can be great teachers. Pediatricians are uniquely positioned to prevent ACEs. So think about the trajectory of people's lives and keep doing the amazing work you're doing. And put out to the universe what you believe in and are passionate about. I did. And then I got an email asking, well, 2 things, actually. I put out to the universe that I wanted to see adults with Down syndrome, and that happened. Put out to the universe that I wanted to do more street medicine, and this happened. So, all right. Awesome.
One of my
Yeah.
favorite take homes is, you're not crazy for caring.
Yeah.
The world might try to tell you that, but just, you're not crazy.
Mhm.